Hi, I'm Dr. Seema Sharma. I'm a senior consultant Ops and Gynae working at Apollo Cradle, Amritsar. I'm also gynae endoscopic surgeon and doing all sorts of laparoscopic work in gynae. Today I'm going to speak on VBAC. First is what is VBAC? VBAC is a vaginal birth after primary cesarean section, and as we all know, cesarean section is on rise, and because of multiple reasons, patients are scared of taking the labor pains, and doctors are scared of going anything eventuality during the vaginal delivery. So that's resulted in increased number of primary cesarean section. So now it's a kind of challenge for the doctors that they should deliver more patients by vaginal route, especially after the first cesarean section. And as we all know, it's a popular dictum, one cesarean is always cesarean, but that was an era of classical cesarean section. And what we mean by classical cesarean section is that there is a vertical cut on the uterus to take out the baby, but that with the advancement of medicine and improved skills and techniques, this vertical incision is now obsolete, and we deliver the babies by low segment cesarean section, in which incision on the uterus is given transversely in the lower uterine segment, and which is associated with very less mortality and morbidity and very less risk of scar rupture in future pregnancies. So now the, you can say, dictum is now changed, and it is now with the once a cesarean is always an institutional delivery. So institutional delivery in what we mean by institutional delivery, that we can deliver the patient vaginally in an institution with at least level 1 services, where we can do the emergency cesarean with team of obstetrician, anesthesiologist and neonatologist. So now coming to who make the good candidates for vaginal birth after cesarean section. So this is very important to understand, where the cesarean section was done for non-recurrent indication, like patients who have undergone cesarean section for breech presentation of the baby, or something happened during labor and baby developed fetal distress, or baby aspirated meconium, or there is some medical illness which complicated the pregnancy, and we had to do the cesarean section primarily. In these kind of patients, if there is a non-recurrent indication, we can select the patients. At least patient during the present pregnancy should have baby in cephalic position, cephalic presentation. Baby weight should not be more than 3.5 kg. Patient should not have any medical or obstetrical complicating factor, and they should not be, mother should not be very obese, or with elderly, should not be elderly mom. So all those factors which are not complicating the pregnancy, present pregnancy, in these cases we can very well select these cases for VBAC, that is vaginal birth after delivery, and we select these patients for trial of labor. And we have seen that in 60 to 80% of these cases with primary cesarean section, we are able to deliver them vaginally, provided their pelvis is also roomy for the baby. So there are certain contraindication, like for VBAC, who cannot deliver vaginally. These are the patients who are primarily having a contracted pelvis, cephalopelvic disproportion, or some of the mothers who are elderly and they are not able to deliver normally, some medical illnesses associated in the present pregnancy, and some obstetric complicating factor like placenta previa or transverse live breech, or some medical illnesses like severe PIH complicating present pregnancy leading to oligohydramnios, IUGR. These are not the patients for vaginal birth after cesarean section. But in a non-complicated pregnancy, we can always take the patient for vaginal delivery and trial of labor. And we have seen that there are many advantages of VBAC. Patient is not exposed to second time, not exposed to operative abdominal procedure, and which is definitely has more risk of complications like excessive bleeding and infection. And after vaginal delivery, patient is recovers very soon, and in hospitalization is minimized, and patient is back to work in no time. So to conclude, I would say that if we select the patient judiciously after first cesarean section, we are able to deliver the patients vaginally in a successful manner, but provided the patients are being delivered in institution with all the facilities for emergency cesarean section, and handling the babies also, because anytime we have to convert the vaginal delivery, a patient who is on trial for vaginal delivery, to cesarean section. Thank you very much.